Good evening, everybody. Welcome to our webinar, ICD webinar. And today we have Dr. Simona from Europe to share her experience, her knowledge with us.
Good evening,
I would like
everybody.
to invite
Welcome to our
John Ling.
webinar, ICD webinar. And today we have Dr. Simona from Europe to share her experience.
I will like Dr. John Ling.
Good evening, everybody.
Tonight,
Welcome to our
introduce
webinar,
Dr. Simona.
ICD webinar.
Dr.
And
John,
today we have
the floor is
Dr.
Dr. John.
Simona from Europe.
Dr. John Ling, you can introduce our speaker tonight.
I have not got her CV. It should be Dato presenting.
Okay. Okay, I will share the CV. Or you mean to introduce the speaker?
Yes,
okay,
please.
then you get on. All right. Okay, Dr. Simona graduated from medical faculty at Comenius University in 1992, specialization in stomatology in 1995. 3 years postgraduate residency at University of Wolfsburg in Germany. Dr. Simona also specialized in orthodontics in 1998, a private practitioner at Dentadem in Bratislava from the year 2000. Doctor's degree, she also obtained doctor's degree from Comenius University and since 2006. Since 2008, she was the head of orthodontic department at the Slovak Medical University in Bratislava. She also obtained Master of Public Health from 2008. Active lecturer at the university and several scientific sessions and international as well as national congress. And she is a member editor board of the Journal of Stomatology and Czech Stomatology. She obtained Master of Science in Lingual Orthodontics at University of Naples in 2015 and a council member of Slovak Chamber of Dentists from year 2002. She's also the chairwoman of the Foreign Affairs Committee, members of Educational Committee, and director of Reversary Committee of the Slovak Orthodontic Society. She is the former president of the Council of European Chief Dental Officers. And she is currently the president-elect of European Regional Organization of Dental Federation. Dr. Simona will talk today on the topic of treatment of class 3 with Invisalign, and Dr. John Ling, our registrar of the section 15 will moderate this session. Dr. John, I hand over to you.
Simona, it's very great for you to present your experience and share with us today. Our president of the section 15 will join us later together. So I will give the floor to you and welcome you to Asia. Thank you.
Thank you very much, Mr. John Ling. Thank you very much to the Professor Hao Kim Xuan and also to Professor Mohammed Ibrahim for the nice help in connecting me and asking to speak to you. I'm very pleased today to be able to speak for the distinguished forum at the International College of Dentists, and I have chosen the topics of class 3. I would share my screen and come to the presentation. Can you see my screen, please?
Not yet.
Not yet. Okay. Just a moment. So. Yeah, all good now?
All good.
Thank you very much.
Floor is yours.
So thank you very much. Speaking about treatment of class 3, I have to start with the conventional treatment and then to come over to Invisalign treatment. We are using class 3 treatment for many years, and you know that we have to start early to be successful in the treatment of class 3. Today, I will let's see you maybe some cases that are not so difficult for you, because I know many of you are very experienced orthodontists and are treating very difficult cases. I will show you a wide range of class 3 cases, from the most easy ones, which only some symptoms of a class 3, to the more difficult ones who ends with surgical treatment. So in the first part of the presentation, I will present you how we treat conventionally the class 3 patients, and then I come to the topic why to use aligners for treatment patient nowadays. And then I will show you some cases about Invisalign treatment of class 3. I hope you agree with this topic. And first of all, for the younger colleagues maybe who attend this webinar, I would like just to review what's the class 3 malocclusion. It's not so nice as in this puppy. In a children, the class 3 is manifested by several ways. Normally, we see it also extraorally. It can be a pure class 3 with hereditary involvement, which is genetic, or it can be a class 3 with just small maxilla, or untrue class 3, we used to say. Class 3 malocclusion, as in any case, we have to do proper diagnosis. This is the alpha and omega of our treatment plan. And then very crucial is the timing of the treatment, also in the class 3 cases. So basically we have a mesio-occlusion intraorally, and we can see discrepancy in several grades between the width and also length of the maxilla, which is smaller than the mandible. But the fold can be divided. It can be too large mandible or too small maxilla. It's just for the recapitulation for students or postgraduates between our attendees to review it. Conventional treatment or modern technology, what should we choose? So at the one hand, with conventional treatment, we know we are sure about the treatment procedures, but the outcome is nevertheless unknown. We appreciate the help of the modern technologies because we can see the malocclusion in digitalized picture, and we can follow the treatment thanks to the digital technologies and compare the progress with the initial malocclusion. And we hope with help of digitalization, we can be faster, more precise, and more custom-made in the class 3 treatment too. So let's come to the conventional treatment. On the picture on the right side, we see a trainer. Just few minutes before this webinar, we have handed out a trainer to a small child. It was a girl of 6 years of age with some irregular growth of the jaws. It is aimed for very young children with mild symptoms of malocclusions, and in a type of children where we cannot, from the reasons of the teeth development or psychological unripeness, we cannot do comprehensive treatment yet because it's too soon, but nevertheless, we would like to help the child to develop in a proper way. So this is the trainer for, is like not custom made, is prefabricated first appliance. We can help the child to develop properly. And then there is something more traditional we have used a lot during my studies in Germany, and that's the Frankel appliance. Frankel is a genius to me. He develops a very nice appliances, removable appliances, and he was successfully treating for decades children with class 1, class 2, but the most famous is his Frankel class 3 removable appliance. And then we have the expanders. As you may remember, in a class 3, the most problems are part of the big growth of the mandible. It can be a narrow or underdeveloped maxilla. We have to expand the maxilla that it can develop further ventrally and also transversally. So the transversal is also in a class 3, our major concern we have to address. So the rapid maxillary expansion is a wonderful tool, even in a class 3 patient, to develop the transversal width of the maxilla. Here we see the type of the rapid maxillary expansion with bands. It's more appropriate with for children with already developed permanent dentition. And on the left side, we see the appliance REM with like lines, like some acrylic part, which is covering mostly used in mixed dentition for the milk teeth. In the middle, we have a protraction mask, and that is what we like to combine with the rapid maxillary expansion appliances. So we're using the protocol, expand first rapidly, and then add the protraction mask for better development of the maxilla forward. So we are pulling maxilla forward and a little bit pushing on the chin to control the growth of the mandible, and then to develop the maxilla ventrally. So very nice combination in our experience. And then for the older children and for the adults, we use class 3 elastics with the multiband appliance. And on the left side, you see carrier distalizer type 3, which is a very beautiful appliance for correction of the occlusion, even in class 3, as we experienced lately. We are using those appliances for class 2 for many years, and several years ago at the market in Europe, we've got available the class 3 carrier distalizer, which is also very beautiful appliance. But we should come to the very beginning, very mild symptoms of the very early symptoms of the class 3. Maybe it's just a frontal crossbite. It can, must not be full class 3 with all the symptoms and all the problematics. It can be just a simple anterior crossbite where we can correct it and then avoid further development of the malocclusion. And this is the mysterious, mystical, marvelous wooden stick. So the spatula. And let's see what we can do with it. This is my first patient I'm showing to you. It's Patrick, 8 years old. And he came to see us with an anterior crossbite, some crowding in the front, and diastema. This is Patrick, extraordinarily nice child in his age. And our treatment plan was in this phase just the correction of anterior crossbite to avoid the worsening of the dental malocclusion. This is the intraoral view. We see the tooth 2-1 and 3-1 is in crossbite, mild diastema. The laterals didn't change yet. The upper arch is irregular, a little bit asymmetrical and pointed, and the lower arch shows crowding in the front and anterior position of the tooth 3-1, which can cause a periodontal problems later if it wouldn't be treated. This is a close-up from the frontal view. Laterally, it's a mild mesial-occlusion, not very heavy case. But already at this age of 8, if we see the mesial-occlusion, then it's a bad sign for the evolution than later. This is the panoramic X-ray. All teeth are developed according to his age of 8. And this is Patrick after 2 months. And he literally just used every day, twice a day, this wooden stick to bite on the tooth 3-1 and behind from palatal side on the tooth 2-1 and just corrected this crossbite. The complete costs of the treatment, of the material cost of his treatment were 20 cents. So it's a marvelous thing. And we start sometimes just with this simple thing. So go from simple things to the more complex. And here we can see before treatment and after treatment. Very nice result, but we have to see the child regularly, at least once a year to see his development. To come to a little bit more difficult cases, or the most difficult I have had in my memory now for the last years. This is Simon, also Simon, 8 years, the same age, same boy, development, everything, but it's a hereditary class 3. So a difficult case. He had really everything, literally, anterior crossbite, small and narrow maxilla. He had aplasia of the lower second premolars, so missing 3-5, 4-5. The upper canines were in retention. He had frenulum breve labii superioris, and beside this, one supernumerary tooth in between the upper incisors, so mesiodens. And his father is a big man of 2 meters height, 130 kilos, and a complete class 3 with a big chin. Looks like a warrior. And this child, everything like his father. You can see here as he came, it was 2014, so back then, with small narrow maxilla. Problem in Simon was his hygiene was terrible. So he didn't brush the teeth very well, despite his parents, they were caring about that, but it was no help. A lot of caries, preliminary tooth loss, and then space management was very difficult. Here you see the complicated frenum in the upper, very broad and deeply inserted. The diastema, crossbite anterior region, small and narrow maxilla. And we couldn't even think about leaving the milk molars in situ because of the aplasia of the second premolars, because they were already very damaged. This is the panoramic X-ray. You may see the mesiodens in between the upper center incisors. And then we see the missing lower teeth in the regio of second premolars, very damaged milk molars, the E's, and very high upper canines. Our treatment plan was extraction of the mesiodens, expansion of maxilla, correction of anterior crossbite, extraction of the 7-5 and 8-5, the E's, and space closure in the lower arch, correction of the class 3 occlusion, fenestration of the upper canines, and alignment into the arch, and frenulectomy. We started with rapid maxillary expansion. Here you see very nice diastema opening in the upper. That is what we would like to see in every patient with RME. And nice development of the upper arch. The hygiene, terrible, isn't it? I'm so sorry. And the boy developing very nicely. He had protraction mask to his RME apparat, and he was wearing that predominantly in the night. Still, when we developed the upper arch transversally and ventrally, his lower arch took this opportunity and grew. That was a constant fight with the growth. This is after the protraction mask and expansion, before fixed appliance was established. We see B-alveolar protrusion, and the maxilla struggles to inner growth. This is the situation 2015. We extracted one of the E in the lower. This is this B-alveolar protrusion width -6 nearly. And we start with the fixed appliance. In the upper arch, we open the spaces for the upper canines. And in the lower arch, we try to close the spaces because of the aplasia of the lower second premolars. Coil springs to create space and elastics change to close the space in the lower on the stainless steel wires. The patient was referred to surgery because of the fenestration of the canines. They didn't come. It was 2017, despite the nice development of the space. And after fenestration, we see the teeth coming. Very nice. We were very happy to see that. And in 2018, we could see both canines coming and the space in the lower jaw is closing. This is Simon, 2020, at the end of this phase of treatment. We could close the space despite his non-compliance and bad hygiene. We could completely close the space after aplasia of the lower second premolars. We could align the canines, which were very high and in retention. And we could establish an occlusion, which is not ideal, but it has some reserve for the class 3 to grow, because we are afraid that he will grow further. He's not at the end of his growth, and we have to see his growth. He has only 3 wisdom teeth. The right lower is missing, but other teeth are root parallelity very good. The canines came very nicely, and the alignment is successful. We still have class 3 skeletally, so this is -5. The inclination of the upper front teeth is good, but the lower teeth are retroclined because of the aplasia and on the reserve, but we fear the further growth. He is growing, still growing. So before and after treatment, comparison, very complex case, very long case, and we used everything we had in the armatory. So that was a conventional treatment, RMA plus protraction mask plus fixed appliance. What can we do in Simon? Again, Simon, that's a mysterious how 2 Simons came into my presentation. This one is 11 years old. Also class 3 with anterior crossbite and vertical decreased overbite, so deep bite. Extraorally, it doesn't look so bad at this age, but we know it will worsen. But intraorally, it's not very good situation. We are in the transitory period of the changing of the permanent dentition. We have a round and broad lower arch, but a little bit asymmetric and narrow upper arch with a lot of crowding in the upper front. Here is a close-up from the front view. Anterior crossbite. Tendency to mesial occlusion both sides. Here is the panoramic. We see the teeth are coming. It's not a very good position of the right canine in the upper jaw, and we have a lack of space for the 3-4 and 4-5. We have width -3, A and B -5.6, and retroclined upper front teeth. So we planned first maxillary expansion and protraction because of lack of space in the upper jaw and small and narrow maxilla. And we want correct anterior crossbite. This is the fixed appliance. We made it by ourselves or with the help of bands and glue, soldering and them on the bands. Our protocol is turned once a day, so it's a 1/4 of the circle, and we do it for 3 weeks usually, and then it's the expansion of 7 to 11 millimeter possible with this Hyrax screw. We check on these children very often, like once a week, how it's going, if they don't have any problems, but usually they are very fine and compliant. Then in July, we removed the appliance and we put him on straight wire appliance in the upper jaw first, then lower appliance to it, and 1925 mechanics MBT with anterior bite stops. So when we finished the treatment in January 21, and we have nice alignment of the teeth, good parallelity of roots, no resorptions. The width is less, is -3 now, and the inclination of the upper teeth changed to 121, and the lower stays 94, which is fine. Nice profile. Nicely developed soft tissue profile, but a long treatment. This is the end of treatment in Simon. This one went better, probably because no hereditary issues. Nice occlusion. Both sides. We put fixed retention on upper and lower. And here you see before treatment in comparison after treatment. What is with patients who comes to you as adults, like Jana? Jana was 34 when she searched our help, and she was class 3. I'm sure you treat a lot of patients with class 3 by surgical approach. And so do we. In adults, you can rarely do some compensation or camouflage when it is skeletal class 3. But here we saw extraoral asymmetry, which disturbed Jana, anterior crossbite and upper midline shift to the right. So the whole maxilla was shifted also. You see it here on the anterior view. The profile is not so bad, but the anterior view is disturbing for the young woman. Here is the panel. We have still 3 or 4 wisdom teeth and a lot of crowding. The hygiene was not so great. And here we see the length of the mandible. The mandible is huge and the width is -10 in the young lady. So our treatment plan was like align upper frontal teeth, extract 2-5, Close space after extraction to find from the front. Remove crowding in the upper arch, and in the lower pre-surgical decompensation, that means worsening of the situation, align lower dental arch, extraction of the 3/8 because of surgical reasons, and remove crowding in the lower arch. And the operation was planned according to the surgeon as mandibular setback. We can see it here, the shift in the maxilla was, the midline shift was because of the extraction of 1/4, that means the right premolar in the young age. So the midline shift was only dental, not skeletal, which is great. And the lower crowding is there, very narrow arch, as you may see, and some space in the upper posteriorly. This is before treatment, 2014. Anterior crossbite, big mandible, small maxilla. And we put her on fixed appliance on Mantibot. Is pre-surgical decompensation, you see creating a negative overjet. Mesial occlusion is worse before surgery. We close spaces in the first quadrant. And this is Jana. At the end of the treatment, you see surgical splints in the lower jaw, which came from -10 to -1. And we could hold the inclination of the front teeth in a good numbers. So the profile improvement skeletally is there. The soft tissue is also nice, softer, but it's the same person. And that was also the wish of the patient, to keep the facial features, but to soften the profile a little bit. At the end of treatment, all spaces are closed. And the recession that was in 3.1 is still there, but it's much better, and we will continue to see it. The hole on the right picture in the upper, who can guess what's that? That's just the small space after the temporary anchorage divide. That. On fixed retention, upper and lower. And here comparison before treatment and after treatment. So, what when we start early, but we have to go on with some kind of appliance after the permanent dentition is in situ. We can choose from several types of appliances, and nowadays the fixed appliance is not the only possibility to offer the children also with class 3. Let's show me Johanna. Johanna was 12 when seeing us. She is class 3 anterior open by this time. Anterior crossbite tendency. She has aplastic 1.5, so missing 1.5 and some spacing. Johanna before treatment, extraorally is not very bad profile. She's a little bit flat, but otherwise not significant changes. And here intraorally we see very asymmetric maxilla with a lack of space and very broad mandible. The tongue is all the time in the mandible, which is very typical for class 3 patients. And we always check on the tongue in these children, on the mobility of the tongue, on the position of the frenum of the tongue. And there is a good collaboration with a speech therapist needed. Johanna before treatment, 2019, still in transitory dentition. Close-up of the occlusal views. Here we see the panel. The canines didn't erupt yet. The 1.5 is missing, so we kept the tooth, the milk tooth. 2.5 is there. Cephalometric data showing -3 widths. The upper fronties are retroclined and the lower fronties were proclined in this case. Our treatment plan. You would guess maxillary protraction and expansion needed in almost all our patients. Intrusion of posterior teeth and extrusion of anterior teeth because of the open bite tendency, right? And rapid maxillary expansion and protraction mask. But instead of fixed appliance like in a boy before, we got here Invisalign teen, and I will explain you later. This is the phase where Johanna was given RME. It was a bonded one. So we have banded one. We saw it in Simon in the first one. And then this is a bonded one when we put acrylic splints on a milk teeth to have a nice disocclusion and good hold. It's opening, the suture is opening very fine. After 2 months, we have a nice arch in the upper jaw. And we keep it 6 months in situ. Yes, so you turn like for 2 months, then you keep it up to 6 months. And the second phase of the treatment, we ended the first part. And we go to Invisalign treatment. She improved fits to 0 just in these few months. And then we kept the inclination of the frontal teeth in good manner. We even improved them, if you can check. We proclined the upper, which was needed in this case, and we retroclined the lower a little bit. And it is the nice developing arch. Treatment will continue with clear aligners at this stage. We give her Invisalign teen aligners, and the treatment plan would be like expand upper arch, create space for eruption of 1-3 and 2-3, translate upper front buccally, intrude upper, sorry for the typo, and lower posterior teeth, and close residual spaces in lower arch from distal to mesial. This is a clean check, which for you that are not maybe using aligners, this is a digital treatment plan for the lady, for the young lady. And let's see how it develops. The red things are attachments on the teeth for the younger colleagues, and then the bite should develop like this. This is the view from sides. And the jump. In anterior, in open bites, you can see in clean check always at the end this mysterious jump. It's just graphical, and you will see it in nature at the patient as smoothly development. So why did we use at Johanna aligners this time? For those who are not familiar with Invisalign, and I apologize if I bother with this theory, the experts between you, among you, but Invisalign is a modern technology which uses digital technologies from the beginning up to the end in producing aligners. Why patients and doctors are looking for aligners nowadays? Because they are removable, so it's very convenient for the patient. They can take them out and eat. For the young children and teenagers, it's a very important thing because they don't care so much about the occlusion, but they do care if they can chew on their favorite food. And it's a very important because of the hygiene. I don't know if it's the same in your country, but in Slovakia, the hygiene of the young children is still discutable, and we have still a lot of children who cannot keep their teeth so well in good shape. And the comfort for the patient. There are nearly no emergencies in these appliances, so it's very well also very good for the patients who live abroad or very far from your place. And it's for sure aesthetics and custom made. Custom made, that means if you buy a pair of shoes because you like the style and the color, but they are a little bit tough and you cannot really walk in them, it's not a nice feeling, right? But if you do custom shoes, then it's something very different. And to me, it's a similar thing with Invisalign. It's something which is made completely just for this patient. It should fit properly, perfectly, and bring us the fantastic result in the short months. There are no dietary restrictions, easy dental hygiene, and the digitalization allows you to show to the patient the outcome, which is very motivating for patients and parents. Let's come to Nina. This is a pure class 3, but just Invisalign patient, so Alina. She didn't come to see me earlier, and she came when she was 12 with class 3, very mild, not enough space for the upper canines, open spaces in the upper front and open by tendency. The profile is not bad, but if she smiles, everybody can see these small gaps between the teeth, and she doesn't like it as a young girl. The hygiene is a mess, really terrible dental hygiene. We tried to get her through the hygiene program, but you have to maintain it each day at home, and that's the problem. Can you see the 2 steps occlusal plane in the lower jaw? This is another good sign, really. And small laterals, no space for the canines. On the left side is worse, and the milk teeth still there in the lower. Some midline shift in the lower arch. Slight mesial occlusion. If you imagine there is still a leeway space, that it would be mesial occlusion on the molars. Close up. And we see we still have 2 premolars to erupt in the lower jaw and lack of space of the for the upper canines. If we would leave it like that, it's most probable that they will either erupt dystopically on another place in the mouth, or they will stop eruption. And here is width -4 in this patient. And under torque, the upper front teeth and a good position of the lower front teeth. We would like to see, again, like in every patient, and I hope you can take it as take-home message here, maxillary expansion. Then extrusion of some of incisors, intrusion of the posterior teeth because of the open bite tendency, opening space for the canines, and mesial movement of the laterals, closing all the upper frontal teeth spaces. And using class 3 elastics. This is the clean check for this patient. Can you see closing of the spaces in the front, opening of the spaces for canines, expansion of the arches, and the small precision cuts on the lower 3 on the canines are for class 3 elastics. This is the lateral view, mesialization of the laterals, and class 3 elastics plan for the skeletal development. Occlusal view of the clean check, expansion, and nicely develop both arches. with enough space for the canines. And this is just 7 months in treatment, very beautifully open spaces for upper canines. The girl refused to extract the lower E's, but we are still waiting for them. We created even a positive overjet, and we have enough space for the upper canines now. And this is the girl after 22 months of treatment, end of the first phase. We can even stop here, but I would like to improve the position of the canines. They just came in, and you see on the occlusal view, they are a little bit mesial rotated, and they are not in full class 1. So we can do it in refinement. The rotation of the upper canines, some extrusion I would like to have, and better class 1 on canines. On the molars, there is a beautiful class 1, and we have here already changed the second premolars, and you see the double occlusal plane is away. This is the panorex. In the lower, we have already retainer on. We have also wisdom teeth. We will observe them. And in the upper, we have very nicely developed canines in a mouse. This is the cephalometry. It changed to width minus 1.5, and the inclination of the frontal teeth is very well under control. This is the cephalometric comparison. And this is the beautiful young girl after 22 months of treatment. Nice arches. And that was her case. I hope you can send more cases, because here comes David. David was 13 years old when he came. He has a concave profile and hypoplastic middle third of the face, but he didn't care about this at all. What he was considered, it was just his front lateral, which was in crossbite, and it looked weird, as he said. He had a protrusive chin, a rather small anterior part of the maxilla, quite okay occlusion, which is mesial on the left side, midline shift, and the crossbite with the lower canine biting over the tooth 2-2. Lower crowding, upper frontal crowding. Here is a close-up from the anterior view with the midline shift. Neutral occlusion on the right side and mesial occlusion on the left side. And here is David's biggest problem, which is the 2-2 in crossbite. Pano without any problematic remarks. Wisdom teeth in situ. Cephalometric shows us minus 2.5 widths, and INB about minus 2, and a very steep lower front teeth. We would like to expand the maxilla, correct the anterior crossbite, because we always have to do what patient's main consideration is first, right? And then open more space for 2-2, give them a little bit more labial crown torque, and correct midlines. We have to correct also the crown of the root of the tooth, otherwise there will be an anesthetic gingiva and bone over the 2-2. And we would like to apply, get more space, and we get it by IPR in this case, and class 3 elastics. Here is the first clean check of David. So let's see. Maxillary expansion, midline shift, opening space for upper left laterals, then IPR, and then retraction of the teeth. This is from occlusal view. You can see the nice expansion, creating parabolic arch form, IPR in the lower front, and retraction. After 9 months, David's pictures. He's wearing class 3 elastics, as you see from the button on the 2.6. 9 months in treatment in 2019. Still some class 3 here, right? But the crossbite is already corrected. After 17 months, we could stop the treatment with improved profile. The concavity is out of the face. The occlusion is good. All teeth are aligned. The midlines are on. And the patient is very happy. So he was so happy that he sent his mom for treatment now. We are grateful for that. The widths, not really better. But overall, the profile, very beautiful. Here is the crossbite and the end occlusion. In comparison, patient in retention, and that was a picture after 13 months in retention. So it's stable. Here is a tricky one. Christina, she came 15 years old, so nearly a young woman. The growth was not so much there, not much left. With a severe mandibular asymmetry and tilted occlusal plane and increased lower third of the face. We were already the third orthodontic office she was consulting. Everybody told her surgery and we won't touch you now. But she was desperate and she told us, please do something because I don't want to be like this in my best years now from 15 till 21. I wish to do something now for my crooked smile. And you can see really it's seen the asymmetry of the face. We weren't sure at this moment we can help her a lot, but she was begging us to try, so we did. And now we are very happy, and I will show you what we did in this girl. So tilted occlusal plane, asymmetrical upper and lower plane, asymmetrical arches, a narrow upper arch as nearly always. Midline shift, skeletally this time, bialveolar protrusion, and some light crowding in the lower front. This was 2018. She had an accident on the tooth 1-1, which is built up. She has wisdom teeth, which we don't really need in this case, and some protrusion, but not so much. We got, if I could hear you, would say maxillary expansion. Correct the crossbite, do some IPR in the lower front to gain space and overjet, and mandibular shift 3 millimeters to the left side was our plan. This is our clean check. Let's see the clean check. Loft of attachments, which help us to help the aligners in mouth, and selective IPR to help the midline. We had also class 3 elastics, which we modified according to the midline shift. And here is the girl after 7 months of treatment. So the occlusion better, the midline beautiful. Very much improved. Nice arches developed. And the asymmetry is still there after 10 months, but it's much better. The smile is much nicer and she's very happy. For sure, the skeletal asymmetry is seen and it won't be better without operation. It's such a young lady, but the teeth are stable now and very beautiful. And we feel that even the asymmetry is a little bit better. If you can judge from the left, she looks a little bit softer and not so edgy. She is very happy after 19 months of treatment. Now in retention, 2 nicely developed arches, the asymmetry is out of the arches, the midlines fit. This is end of the treatment, so the teeth have to settle a little bit. But otherwise, very nice. The wisdom teeth, no effort to come through. I would suggest to remove them. This proclination, this is the calf comparison. You can even here see the asymmetry of the jaws. It's improved nearly 3 grades. And lower teeth are upright, more upright, upper state. So overall duration 19 months, very beautiful outcome, even extraoral is seen with 44 aligners. And here comparison, before treatment and after treatment. And 3 months in retention. The settling came in and the hygiene is much better, which I'm personally very happy about. Let's see Enrico. Enrico is also a 15 years old boy. He came with anger class 3. So you see, we go to the older teenagers now. He has deep bite face asymmetry and lower frontal crowding. Extraorally nothing very serious, but also asymmetry of the jaws. The left lower jaw is more massive. Here's a bruxer, and you see some atresia of the lower front teeth, abrasia, asymmetric upper jaw, and very badly shaped laterals in the upper. We see rotated canines, very pointy canines in rotation, deep bite, and not very nicely formed laterals. Slight class 3, both sides. Edgy lower jaw, rather narrow, asymmetric upper. This is the panel. Again, just 3 wisdom teeth. Wow, I have to really look at this and make a research about the development of the wisdom teeth in our patients, because this is the 3rd case already in this presentation. We have just 3 of them, right? If you keep the counting. But otherwise, nothing very special. Here we see it's minus 4.6, more than we would expect from extraoral, and under-torqued lower front teeth and upper front teeth. And we want, I can really hear it from you, maxillary expansion, raising the bite here, intrusion of the centrals in the upper, to do labial crown torque of the upper front teeth, and to rotate the laterals. This is the clean check of the patient. And we see bite opening, rotation of the laterals, intrusion of the upper front centrals, and overall releasing the crowding in the lower front. Here is it from side again, the same. Bite opening is here, the big issue. And this is Enrico after 3 months of treatment. some improvement already seen here. Bite opening is going very well, but it's still on the way. Nicely formed upper arch. Can you see after 3 months of treatment, the nice shape of the upper arch? And this is already the end of the treatment, which was only 14 months in Enrico. He's very happy about that. And the teeth, the bite is completely vertically improved. The canine occlusion is neutral. He has good contacts and nicely formed arches. If he's older, he can think about build up on the laterals, but at this age, I wouldn't do it. And this is the occlusal view in Enrico's after 14 months of pure aligner treatment. Panoramics, you see very nicely parallelity of the roots. And the 1A didn't appear, and it won't appear. Cephalometric, width didn't change much, but the inclination of the lower teeth improved significantly, and upper also. So the profile, very similar, but it's good in this patient. The lower third has risen. And this is the comparison before and after treatment in Enrico, 15 years old, just 14 months with aligners. Here's some issue with his skin, so getting medicaments because of the skin, causing some erosion on the lips. I'm sorry for that, but the teeth are beautiful. 8 months in retention in Enrico. We took these pictures in March 2020. Everything is nice, stable, and very naturally looking. So to move from these teenagers to adult patient, let's show me Adam to you. Adam is 44 and he was orthodontic patient in some other clinic many years ago because he was hereditary class 3. So they did operation on him, orthodontic surgery. Something went wrong with the occlusion after the further tertial growth maybe. And he came to me because he felt the crowding is not good, the teeth are flared, he has deep bite, and he wants to do some improvement. He is class 3, also extraorally. Despite this dangerous look, he's a very nice guy, very good patient. But in the mouth, we see this situation. So a little bit narrow upper arch, over inclination of the upper frontal teeth, which are flared, very lingually tilted lower teeth, and narrow upper arch. This is all before treatment. The occlusion is not bad, it's just slight mesial, like quarter mesial, 2 millimeters mesial occlusion, both on canines and molars, and crowding in the lower front teeth. And he is praxis, so he's grinding his teeth all the night. He's also very big and tall man. And what you see there in the ramus, right and left, this is the suture which was made many years ago at the clinics after orthodontic surgery when they didn't have the plates yet. This is width -9. An over inclination of the upper teeth. We would like to align the upper front and open a little bit the spaces between the upper frontal teeth for some ceramic veneers, and distalize a little bit the lower posterior teeth, release lower frontal crowding, and intrude slightly the teeth. And we gave him class 3 elastics. And he, being a good patient, accepted this clean check, which is basically bite opening, just a little bit expansion, and the greenish quadratus means there will be 0.5 millimeters space between the frontal teeth later for build-ups, because there was a less mass of the upper front teeth as in the lower, so some Bolton discrepancy, and we want to solve the Bolton discrepancy basically by making the upper frontal teeth bigger. This is the progress after 8 months. Adam is wearing his aligners very well. The brushing is not so perfect, and he drinks a lot of tea. You may see it in our countries also, that tea is very, very bad for the color of the teeth, but very good for the health. I love it. And here is Adam after 2 years in treatment. We have nice class 1, which I'm very happy about. Nice bite opening, and still working on the spaces. This is a panoramic X-ray after 26 months, and now he is ready. We could reduce width to 2.7, which is great, which is really, really good. And here is his profile, and he likes his new chin better. And now he is ready for veneers in the upper front. So he's waiting actually for the veneers. And then next year I will show it to you. And here is Adam. Adam is 17. Another Adam, right? This is crazy. The names are real. And it's repeating itself. It's angle class 3, spacing is upper front, little bit big chin, dominant, not so bad in the boys, right? Some spacing in the upper front, over inclination of upper frontal teeth, but spacing in the lower front also, in the around canines. We call it monkey spaces. Lingual torsion of the posterior teeth in the lower, which is typical for big jaws, right? For big mandibles. Open bite on the 1-2 because 1-2 is very small. Again, the occlusal views. Here we see panoramic X-ray, nothing very fancy, a part of the dancing roots. Can you see them on the upper molars? Very funny, dancing roots. And here is a nice cephalogram with a width -6. The lower front is being a little bit lingually inclined, and we want to change. We want to expand upper arch, so expansion of the maxilla. Consider position 2-3 as anchorage and mesialize upper teeth. Extrude upper laterals. Sorry for the double sentence here. And at class 3 elastics. This is the first clean check of Adam. We did just some IPR, not so much. We try to do less if possible. From the side, we retract a little bit the lower front. We close the upper spaces. And here is Adam after 12 months of aligner treatment. Very nice outcome. The only thing I would wish here at this stage is a little bit more extrusion of the laterals, but those of you who are treating patients with aligners, they know the upper laterals are the most tricky teeth. So maybe bigger attachments would help the extrusion of the upper laterals. But overall, I'm very happy with the outcome. Pano. The wisdom teeth are developing well. Here is the calf. We got some reduction of the width. We developed a nice profile, which was concave, now is more straight. And after 12 months, the young man said, okay, guys, I'm happy. I quit here. So let me do. And I said, I wish to do longer laterals in you. Would you be with me for a couple of months more? And he said, yes. And I was completely happy about this because I can do this even better. And then I happily release him. And herewith, I would like to release you from my presentation, but I would first of all give you a take-home message. So my take-home message would be that remember that the class 3 treatment is a long way run. So you start early and you probably see the patient for years. Even if you just check on the patient, but you really bond to the patient, you know his family, you know his or her anamnesis very well, and you just observe them to growth, because the growth is on the other side of the barricade in a class 3 patients. It will do everything to do our life a little bit more interesting, but more tough. The growth will use all the space you give to the mandible will grow to it. So you expand the space of the maxilla, you give some protraction of the maxilla, and the mandible will jump to this space and use it smiling. So it's a long way to go. The second thing I would like you to remember, please, is about digital technologies. They really, in my opinion, help precise the treatment of teeth, and they will allow you to be perfect and more predictable and motivating for the patient and controllable, because what we think is one thing, but what we can show on overlapping of digital scans is the other things. The third message would be that aligners are very beneficial in light of moderate class 3 cases with no surgery. But if you wish to treat skeletal class 3, the best results you achieve with surgery or combination surgery and orthodontics with Invisalign. You can easily also prepare patient for surgical treatment with Invisalign. So either you go for fixed braces or you go for aligners. You can prepare before surgery the decompensation. You can give them aligners through the post-surgical phase, and you can finish them very easily and nicely with aligners. And next time, it would be a very good topic to show you some surgical cases treated by aligners from the beginning to the end. So here is the end of my presentation. I would like to show you a nice picture of my city, Bratislava, where we have a beautiful castle. We were for some years the coronation city of the Austrian-Hungarian monarchy, and we would like to invite you, if you have the road in the Central Europe, to see also our small city Bratislava, which I love overall. We have a nice churches here. We have a beautiful fountains. What I can recommend you is an easy walk in an old city of Bratislava, which is rather small, but very ancient and beautiful. And then you maybe decide to take a boat over the river, which is called Danube, and is going through nearly whole Europe, Central Europe at least, having his origin in Germany, in the Black Forest, and ending coming into the sea in Romania, so in the Black Sea. So it's a river which connects a lot of countries, and you can take a boat in Budapest and go up the river to Vienna, and directly in the middle you have Bratislava. You have to stop, jump out of the boat and see me there. So thank you very much, and I hope to see you next time in another interesting presentation.
Thank you very much, Dr. Simona Dianiskova. Thank you very much. It's a very, very impressive presentation, and you bring me to the fond memory of Bratislava. Yeah, and that is a very nice Danube River cruise that I've been to, and I also at the crossroad where they show the picture there. I have a very good memory there. Thank you. Beautiful city and beautiful presentation also. Here, I would like to invite the audience to ask questions. I do have a first question here from a participant here to ask you: do you keep anterior fixed retainer forever? The fixed retainer.
Yeah.
Forever.
So thank you very much for the question. This is the question all my patients are asking me. Should I have this forever? And I used to answer them, no, keep it only until you wish your teeth are completely straight. So with the fixed retention, it's the thing. I'm not really sure if my patients are so disciplined that they would wear the removable retention for many years. So for me, it's a like double security to give all of them, or nearly 95% of my patients get it after finishing the treatment, both upper and lower fixed retainer, because I wish to be sure that their frontal teeth at least are completely straight after many years. So I'm not so old, so I cannot say if it's forever, but my retentions are in place over 10 years, and for sure I maintain them. So there is some maintenance needed. You have to see your patient to check on the fixed retainers, to do some improvements on it. And I think it's very important to keep them long on the teeth, you know. So forever is maybe a little bit strong word to me, but for several years. So I'm very happy if they stay at least 10 years on the teeth. If then they are breaking, or there is some relapse because they didn't come and there is some rotation, I remove them. I don't force them, and I don't redo them on a little bit crooked or spaced teeth. So at this point, if there is already a problem with the alignment, I remove them and leave just the retention which is removable, or some small correction, like 1-2 aligners for a small correction, and then to keep the removable retention.
Okay, so meaning that when you remove the fixed retainer, you will replace it with a removable retainer, or you just leave them alone without any further retention? So
after remove them, I usually keep the removable retainer for some time and then slowly reduce the time of removable retention. That means that the first year, maybe after having only removable retainer, they should wear it really each night. And then the second year, maybe every other night. And to come at least to have it for a long time, at least once a week or twice a week, just to check if everything is okay. It's just for the patient also. If they don't want to see me, at least they can check if the retainer is still fitting. Of course, the retainer, they won't last for forever, and they have to be renewed also. But sometimes there is there is an end to the orthodontic treatment, you know, but basically the patient should be satisfied with the teeth appearance.
Okay. I have a second question from Shirley Ganda. She asked, right, to what extent or the limitation of adult patient can we expand maxilla using the aligner? That's the first question. The second question that she asked is that, what is your modifications, attachment, or refinement for extrusions or laterals? All right, so two questions. One is that for adult patient, how much can you expand the maxilla using Invisalign aligner? Number two is that, how do you extrude the lateral and what attachment do you use? All right.
Thank you very much. This is a very good question. And the answer is not very simple one, because you have to see always, if it's an adult or if it's a child, but mostly on the adult teenagers and adults, you have to see if you need real expansion of the maxilla or if you need just expansion of the dental arch. You can judge that obviously also on the buccal torque of the posterior teeth and of the apical basis of the alveolar bone. If you need if you need bony expansion, so it's better to go for something which is really working in a bone. That means surgically assisted rapid maxillary expansion or bone bore Hyrax appliance in the younger adults. This is for skeletal expansion in older teenagers or young adults or adults necessary. Sometimes if it's very severe, you even have to think about upper jaw surgery, which can divide the maxilla in 2 pieces or even 3 pieces, this epsilon osteotomia of the maxilla, and you expand purely surgically. But in our hands, the rapid maxillary expansion surgically assisted is a very, very good way to expand. And you can combine it then with aligners, either in the preparation or after the stabilization of the bone for alignment of the teeth in the new wider maxilla. When I have to expand dental arches in adult patients, so change the inclination, it's very important to stay, for me, there are some limits and I never expand more than 6 millimeters. So basically, usually it's around 4 millimeters in adults, but never expand more as the 6. The teeth can first be expanded in buccal region, the crowns, but then you have to think also to bring the root buccally. So you have to add some buccal root torque to your teeth, and you write it down, please, for your dental technician who is helping you to achieve this movement, that you don't have only pure tipping of the teeth, which wouldn't be very nice situation. I hope I could cover this part of the question. And the second question was about the laterals. The upper laterals, as I told you in the presentation, are tricky teeth to move because they have small crowns, they have very round apex, very round root, and you have to catch them into the aligners, which is not always very easy because they are between 2 big teeth, the laterals with a big crown and the canine with a big crown and huge root. So the lateral sometimes slips out of the aligners and is not following the movement they should have. So you can aid it to ask the technician, and the technician will give you some optimized attachments for extrusion of the laterals which is very advisable to use. And please ask him to take a bigger attachments. What I have learned in the last 2 years, the bigger attachments, optimized extrusion attachments, are much better functioning as previously the small ones. So that would be my advice to the optimize. And if there is no possibility to give you optimized attachments to these teeth, because you cannot do it by yourself in the 3D control, you have to ask for it. But if for some reason it's not possible to accommodate the extrusion attachment, then use a big rectangular attachment for helping the holding aligner and helping the extrusion. But normally you will be pleased with the optimized extrusion attachments for the upper laterals.
Thank you very much for your clinical tips as well as the sharing of optimized attachment. All right, so now one question from me is that you have shown that the use of removable class 3 like Frankel, all right, and also rapid maxillary expansion, to the use of fixed appliance, and then to the use of Invisalign in the management of class 3 in all ages. All right, what in your opinion is the best appliance system to treat class 3?
That's a very tricky question, but thank you very much, Professor, that you are asking that to me. So I have to tell you, in the past, during my studies in Germany, I have seen beautiful cases treated only by Frankel 3 appliance. But I used to say here that here my patients are not Germans. Germans are beautiful patients. German children would wear the appliance all the night for sure, and half of the day in the school every time they could, you know. So they are beautifully disciplined patients, and the doctors got very nice outcomes also with the removable Frankel appliance. It's not the case in our children. Our children are not so disciplined, I have to say. They are very beautiful and kind, but not so disciplined, and they wouldn't take the removable appliance into the school. So that is a problem culturally here in Slovakia. So I couldn't see so many good results with Frankel only. But it's a beautiful appliance if you use it for retention of class 3 cases in growing patient, because it really motivates the bone growth in the alveolar parts of the bone, and the proliferation of the bone is much more in the areas you need it, for example, in the upper frontal fornix, you know. So, and it also can keep your lower frontal teeth in control, and there are big buccinator plates from composite, which will just pull your tongue, not tongue, but pull your cheeks away from the compression of the maxilla. So it's a beautiful retention apparatus after a correction of the class 3. And I use it also for children where I know they are out of the envelope, skeletal envelope, for a possible compensation or camouflage, and they will probably end up as surgical cases in the future. So I don't give them any fixed appliances or something more invasive, but I do them Frankel appliance for the night just to control a little bit the amount of growth and to moderate the type of the malocclusion they will probably develop as adults. Regarding the fixed appliance, is a very good thing to use in a class 3, but with, for example, some extraoral traction like carrier or the protraction mask also to the fixed appliance, or this class 3 elastic. It works very well in the borderline cases and also in the mild and moderate cases. But in the last few years, I liked very much the aligner treatment in this patient. And the reason is I can use my class 3 elastics from the day one they get the aligners. So I don't have to wait until I'm on the stainless steel wires rectangular to get them class 3 elastics for the correction of the class. So therefore I like aligners most probably now.
Thank you. Okay, I shall now request my co-moderator, Professor John Ling. Professor John Ling, over to you.
Good evening. I'd like to ask just a couple of questions. If you have a patient with poor oral hygiene after you have inserted the aligners, what could you do? They're non-cooperative.
Yeah. Thank you very much, Professor Ling, for this question. So first idea I get if I see a teenager or child or adult with a poor hygiene with aligners, then I say, thank God I didn't give him fixed appliance. And the second thing I tell the patient, they should regularly visit the dental hygienist, so make an appointment in the dental hygienist to get professional counseling on the dental hygiene and cleaning. Probably they will need more often the dental hygiene. That means more often means every 3 months if there is no pathology. And then I counsel them on the using all the stuff at home, what can help the hygiene, and advise them. I try to take the anamnesis. So I try to think why the hygiene is worse. I check the previous photos, if it's a chronic problem of the patient to have not such a good hygiene. And if not, then I ask him, what did he change after he was getting aligners? So I ask him, do you eat with aligners? Because I generally advise my patient not to eat with aligners. So remove them before eating and then either brush these or at least take some water and spit out the dirt and then to put fresh aligners into the mouth. So if I see the hygiene is bad, one of the first ideas is maybe the patient is not removing the aligner when eating. And then, so I advise him to do so. And if the hygiene is not better next time, maybe a good idea is take some gel for fluoridation and put it into the aligners for the night when they are going to sleep.
Thank you. Back to a question about expansion of the maxilla. You spoke about putting root torque on the bolus. Is there a warning that we are pushing the roots labially, that you may have recession in some adult patients?
Sure, you are absolutely right. And in all adult patients, when we would like to do any expansion of the maxilla, I would advise to make a CBCT, a cone beam CT of the bone, that we can see if there is sufficient bone present for any expansion. Because as you said, it's absolutely right that the recessions on the posteriorities after expansion are a very bad management of the treatment.
You have to ignore my ignorance about attachments. Can you enlighten me, some of the audience, that why are there so many different type of shapes of the aligners, the attachments? If you say some of them are in different shape, what are the shape differences? Make any difference to the movement of teeth using a removable appliance, which you want to grab the teeth, basically?
Yeah. So it's a whole science behind the attachments, and some companies producing aligners claim that the attachments are very important to be various shapes and sizes, and it's because of the biomechanics of the forces. It's a little bit similar as when you think in sense of biomechanics of fixed appliances. That means of the forces which are posing force on the tooth in various directions, and of the couple of forces. And this is possible in aligners through the attachments. There are basically two types of attachments if we divide them, and one is these optimized attachments, and one is conventional attachments if we are speaking about attachments using by Align technology. And the optimized attachments have various sizes, which I would say basically the bigger sizes to me in my hands work better because there is more surface for the aligner to grab the attachment and to push in the direction we want. And also we have double attachments. And the double attachments can be posed, that means in one tooth we have two attachments or a pair of attachment, and one is in the opposite direction as the other. And then we can also use double attachments in one tooth. That means, but this is your decision as clinician. They rarely will suggest you from Align, the technicians, to do it, but you can ask for one attachment from the buccal side and the other from the lingual side. And this is more for the reason of a stability of aligners and grabbing better the tooth. And then there are these conventional types of attachments, which can be also various types. They can be usually rectangular, but also oval. I have to say, I beg your pardon, but the ovals are not so good working in my hands. I prefer the rectangular ones, and I prefer in the 3D controls to change their inclination on the tooth, that they work in a mode I imagine the force should be applied on my tooth. And the optimized attachments can do extrusion of the teeth or enhance the extrusion. They can enhance root torque or root movement. If you, for example, have extraction case in aligners, then if you put a couple of optimized attachment on the neighboring teeth, then you get this preferred movement of the, so first crown then root, first crown then root, that we also use in some mechanics, in biomechanics, in closing spaces, in fixed appliances. So it's possible to expect this type of movement even in the aligners, and which is a proof that the aligner can move also the roots is for me the panoramic X-ray later, when I see even in extraction cases that the root did the way too, and it's also helped by the attachments, not only the aligners.
To follow this up, why are the attachments mainly placed on the labial side, not on the lingual side?
From the
because
lingual side,
if this is because some of the patients do complain that these knobs, the teeth.
Yeah.
So why can't, or there are different reactions of the appliance to the teeth if we place it lingually, which such as lingual appliance, right? So, you know, it's placed lingually. There's nothing in the labial. And of course, some aligner companies are claiming that they are doing non-attachments.
I see the point, and it's completely right. If you would like to offer to the patient an aesthetic solution and you give him an aligner with a lot of frontal attachment, the the aesthetics is compromised. But from the biomechanical point of view, it's much better to give the attachment on the labial side because the aligners are a pushing, not a pulling, but a pushing type of appliance. So it's better to have them labially. For sure, I have some patients, and it is in my practice, it's either a very socially exposed person in a adult age, which that cannot show any attachments, where I put it lingually, but the treatment is usually then a little bit more complicated or longer. And the second person where I would put the attachments only from lingually or no attachments at all is a person with very compromised quality of the dental enamel, even children who has some dysplasia of the enamel. I wouldn't place attachments here at all.
What about if you have patients who have very short and round morphology, which plastics are difficult to adhere to? What can we do about that? Say the short crowns or very rounded oval teeth, or patients already have some porcelain crowns or some prosthesis made.
Yeah.
So how do we get over in treating those short crowns?
It's a problem. Teeth? Yeah, it's a problem you are tackling here. Nevertheless, I think there are two types of these persons. Either they are adults with permanent teeth, which are typically short crown, either after abrasia. In that case, I would ask to some build-ups preliminary before I start the treatment with aligners, where the tooth mass was lost due abfraction because of bruxism or incorrect bite. So the build-up preliminary with a composite or with a temporary crown would be here advisable before we start the treatment with aligners. Then the second thing which can help would be to put a lot of attachments on the teeth, because the attachments have a very good retention function. And if you take a lot of them, then the retention of the aligners will be better. What I wouldn't advise is to go over the gingiva with the aligners. So I would let them cut to the cement enamel junction, not farther up, like some systems show us. And the second thing is, if you imagine, we use now aligners also in children, small children from the 6 years of age until 10 with the product first. So the first aligners. And usually the milk teeth are very small crowns, right? So here we see an example that it can work, and it really works unless the children have a big gaps in between the teeth, because in these gaps there is a locus minoris resistentia. They tend sometimes to break in these spots, but unless this is the case, then the short crowns are not a contra in using aligners. But I would add a couple of more retention attachments by myself when judging the clincher coming from the company.
I'd like to ask one last question from me. Sometimes we do see posterior open bites. You mentioned you can expect them to erupt into occlusion. So how long can we wait until we say we need to do something that you can only touch in the front and not at the back?
Mm-hmm.
I mean, settling the occlusion.
In settling, yes. So it is different in settling in what we call fixed appliance, and also a different approach I have in aligners. So in fixed appliance, I use 3 of many types of settling possible. So the most I use is to put the patient on the light wire at the end. So after a phase of the working wire, which is usually in my office, in a 22 slot is the 1925 stainless steel wire in upper and lower. And after the finishing the working phase and some weeks of letting it without any movement, that I have learned from Mr. Professor Alexander, who told me, let it cook. That means let the last wire work, even if they don't, you move it. And it's difficult with the patient because they see everything is straightened and they just asking when the braces come off, because you are not doing basically anything, but it's important. So the first possibility is change these wires for a soft wire and let the person to wear some intermaxillar elastics on this wire, like up and downs. But usually I prefer not to extend more than 2 weeks with this settling phase.
No, basically I want to ask about aligners. Because
Yes.
if you have the aligner, you're holding them.
Sorry.
We keep it to the question of because we are the topic today is Invisalign.
Yes, sure.
Yeah.
So with the aligners, if very important is to see if the patient is not biting on several posterior teeth, or he is prevent to bite because he has preliminary contact in the front. This is very important, because if you have preliminary occlusal contact in the front, it will be difficult to get the good settling in a posterior teeth because there is some posterior bite. So I wouldn't like really to finish in this situation. And every time I ask the clinical technician, please give me interincisal clearance in the teeth. That means he understands that I don't want to have contacts in the front when I'm finishing. And I really check it in every my clean check if I'm not planning this. Nevertheless, you get it sometimes that the patient is biting on the front. So if I have time, I try to go out of the frontal contact first, and then to improve the posterior contacts by extrusion of the posterior teeth. You can ask for extra aligners to get you this one. So it will be better to get some attachments on the posterior teeth for extrusion. This is the one possibility, and try to really not get contacts in the front. In any case, you avoid at least the red contacts. This is the preliminary heavy occlusal contacts in the front. And my second advice is not to ask for very tight overjet. So if your overjet is less than 1.5, then you are very likely to get the preliminary contacts in the front, and I don't want this. So if I'm planning my cases, I really don't like to accept overjet less than 1.5 at the end planned. And if I finish the patient and I see there is really some teeth not occluding really properly, then I may choose just to cut the last aligners after canine and let the patient wear it like this for 1 or 2 weeks. And then usually it settles well.
Thank you. I have, Dato, I think 2 participants raised hand. I don't know how they can ask the question.
I think
maybe we invite them to type it into the chat box and ask the question. I cannot see them.
Are they able to unmute themselves? One is just one thing, you're allowed to talk. And then the other one is followed by Valin Sun. You're also allowed to unmute yourself and to ask question. Dr. Jaswant Singh is an honorary fellow ICD, right? He's very senior. All right, so Dr. Jaswant Singh, you can unmute yourself and speak up. Jaswant, are you there? Okay, now maybe we try to ask Dr. Velin's son. Okay, Dr. Velin, you can unmute yourself. You are given permission to speak right now.
I'm very impressed by the lecture given just now,
Okay.
and I'm grateful to ICD for arranging such up-to-date lecturers to give us all this latest knowledge. Thank you so much, Professor
you.
Ibrahim, Professor Howe, and our speaker. Thank you so much.
Thank you, Jaswant. Thank you. It's always very nice to have you. You are the most respected person here in Malaysia, our honorary fellow. So thank you very much, Dr. Jaswant. Okay, Dr. Valens, do you have anything to say?
Yeah, you have been treating my granddaughter. I'm
I'm
very impressed, and she's very happy about it.
Oh, she's also wearing Invisalign, yeah?
Next week she might come and see you.
Right.
Perfect. Many greetings. Thank you
Hi.
very much.
Nice.
Thank you.
Thank you so much.
Thank you. Thank you, Dr. Jaswant.
Yeah, good night.
Good night.
Thank
Okay.
you. Good night. Thank you very much.
Right. And Dr. Valens, you are allowed to unmute yourself and please ask questions. I did not see any response. Okay, so I think the time is kind of late already. So I'm going to pass this to our education chairman, Professor Muhammad Ibrahim. All right, he may have some housekeeping matter and also some announcement. And once again, I want to thank our distinguished speaker here, Dr. Simona Dianiskova, for a very excellent presentation. This is the second time we invite you again. I'm sure we will be inviting you again to hear you for another very impressive lecture also. Yeah, we are truly very impressed by you. Thank you for sharing your precious knowledge with us. Professor Ibrahim,
Very much.
over to you. Thank you.
Thank you very much, Dr. Howe, and also Dr. John Ling for moderating the session. And thank you to our speaker, Dr. Simona, for her excellent presentation. And as what our president said, this is the second time that you have shared your knowledge with our viewers in this section. And we hope that we can meet again sometime in future, maybe for another topic on your specialty. Okay, again, on behalf of Section 15, I would like to thank you, our two moderator, who is also an office bearer of Section 15, and also to our speaker, Dr. Simona Dianiskova. So now I will, as usual, I will share what's up for us in 2 weeks' time. All right, so what I can say that in 2 weeks' time, we will have what we call this another talk from one of our region from Bangladesh. Okay, and he is Professor Dr. Mutiur Rahman Molla. He will talk to us on oral precancerous lesion, a clinical study on various pathology and a modified management protocol. So I hope that you all will join us again on the 10th of November, same time, Malaysian time, 9:30, to listen to our speaker from Professor Dr. Mutiur Rahman from Bangladesh on oral precancerous lesion. Till then, hope that we will meet you again in 2 weeks' time, and have a great evening and have a good rest for the day. Thank you very much, and bye-bye, and see you all later. Again, thank you for the support.
Thank you.
Thank you very much. Good night.
Good night. Bye-bye. Okay.
Thank you very much, Prof.
Bye, everyone.
I really appreciate your hard work. Thank you so
My
much.
pleasure, Dr. Son. You always join us every. I said one time you miss, otherwise you'll be all. So thank you.
I don't miss this sort of interesting talk.
Okay. All right. Thank you.
Okay, good night.